It turns out that in psychiatric nursing, the most effective way to build a therapeutic relationship isn't by giving advice or offering reassurance, but by something far more subtle and consistent, simply being reliable and consistent in care.
Really? That's kind of counterintuitive, isn't it? I mean, we often think that telling patients what to do or reassuring them is what builds trust.
Exactly. But consistency actually promotes trust and security far more than advice or reassurance ever could. It's a fundamental shift in how we engage patients and ultimately impacts outcomes in mental health settings.
That makes a lot of sense when you think about it. Patients need to know they can count on us, not just hear what we think they want to hear. So what are the key foundations behind this?
Well, Peplau's model gives us a great framework. It breaks the nurse-patient relationship into 4 phases: pre-orientation, orientation, working, and termination. And the pre-orientation phase is often overlooked but critical.
That's the phase before you even meet the patient, right? What happens there?
Right. It's all about reviewing available patient information and self-reflection. So before the first encounter, the nurse gathers data and mentally prepares. This helps prevent countertransference and boundary issues later on.
That's interesting because it's not about jumping straight into the relationship, but setting the stage carefully. And then orientation is where trust and confidentiality come in.
Yes. During orientation, the nurse discusses confidentiality, clarifies roles and expectations, and establishes the therapeutic contract. Setting clear boundaries here is essential to avoid violations down the line.
And then the working phase is where the real behavioral change happens?
Exactly. That's when the nurse actively facilitates coping strategies and problem solving with the patient. It's the core of therapeutic work.
And termination wraps things up by reviewing goals and preparing for closure, which can be emotionally charged.
Yes, and handling that phase well is crucial to maintain therapeutic gains.
So going back to the therapeutic relationship essentials, you mentioned consistency is key. What else forms the backbone?
Trust, respect, empathy, genuineness, positive regard, and boundaries. But I want to highlight empathy versus sympathy, because that's a common pitfall.
Right. Empathy means identifying and reflecting the patient's feelings without judgment, while sympathy can sometimes come off as dismissive or inaccurate.
Exactly. For example, if a patient says, "Nobody cares if I live or die," an empathetic response would be, "You sound very alone right now." Saying, "I know exactly how you feel," is sympathy and can feel invalidating.
That's a subtle but important distinction. And boundaries. What are some common violations we need to watch out for?
Meeting patients socially after discharge or accepting expensive gifts are classic boundary violations. Nurses must maintain a therapeutic focus on patient needs and avoid self-disclosure that blurs roles.
And when nurses notice strong feelings of dislike or over-identification with a patient, what's the best approach?
Self-reflection is key. It helps prevent countertransference. Immediate reassignment or confronting the patient isn't usually the best first step.
That's a good reminder. Now, shifting gears a bit, let's talk about assessment tools. HESI is one that comes up a lot with adolescents.
Yes, HESI is a psychosocial screening tool covering 7 domains: home, education or employment, activities, drugs, sexuality, suicide or depression, and safety or violence.
And the H stands for home, not health or hope, which is a common mix-up.
Exactly. For example, asking an adolescent, "Tell me about your relationships at school and home," assesses the home and education domains.
And if a patient reports suicidal thoughts during HESI, that requires immediate follow-up, right?
Absolutely. That's a red flag that can't be ignored.
What about COWS? That's the clinical opioid withdrawal scale?
Yes, it's used to assess opioid withdrawal severity by scoring symptoms like restlessness, sweating, yawning, pupil size, gastrointestinal upset, tremor, anxiety, and irritability.
So if a patient's CS score increases over time, that indicates worsening withdrawal?
Correct. That signals the need for reassessment and intervention. And common opioid withdrawal symptoms include lacrimation and yawning, not bradycardia or pinpoint pupils, which are signs of intoxication.
That's a crucial distinction. Now, harm reduction is another big topic that often gets misunderstood.
Definitely. Harm reduction isn't about enabling substance use. It's a pragmatic, patient-centered approach aimed at reducing negative consequences rather than insisting on immediate abstinence.
So examples would be naloxone education, needle exchange programs, safe consumption sites, and providing non-judgmental care.
Exactly. Nurses adopting harm reduction might say, let's discuss ways to stay safer, instead of, you must stop immediately.
And this approach recognizes addiction as a biopsychosocial disorder, not a moral failing or lack of willpower.
Right. It integrates biological, psychological, and social factors. Plus, relapse is seen as a possible part of recovery, not a treatment failure or manipulation.
Trauma history is also a significant risk factor for substance use disorders, which highlights the need for trauma-informed care within harm reduction.
Yes, that's often overlooked but critical.
Now, what about managing oppositional defiant disorder? That's a challenging one.
ODD is characterized by persistent defiant, argumentative, angry, irritable, and vindictive behavior, especially toward authority figures.
It's important to distinguish it from psychotic disorders or developmental delays, since hallucinations or memory loss aren't features of ODD.
Exactly. Nursing interventions focus on clear limits and consistent expectations rather than inconsistent consequences or punitive measures.
Avoiding power struggles is key. Maintaining structure and predictability helps reduce oppositional behaviors.
Right. Consistency, again, proves essential.
Finally, therapeutic communication and use of self-active listening is foundational.
Yes, simple prompts like "go on" encourage patients to elaborate without judgment. Reflection, such as, "It sounds like you are frustrated because your treatment isn't progressing as quickly as you hoped," validates feelings and promotes insight.
And we should avoid false reassurance or changing the subject, which can undermine trust.
Therapeutic use of self means intentionally using communication skills to benefit the patient, not oversharing or becoming emotionally dependent.
So to wrap up, mastering these foundational concepts, therapeutic relationships, assessment tools like HESI and COWS, harm reduction, and managing disorders like ODD really empowers psychiatric nurses to provide nuanced, compassionate care.
Absolutely. It not only improves clinical outcomes, but also prepares nurses to navigate the complex ethical and emotional challenges inherent in mental health nursing.
And remembering that consistency, empathy, and clear boundaries are the pillars makes all the difference.
Couldn't agree more. Those subtle but powerful elements shape everything else.
Well, that was a solid deep dive. Hopefully listeners find these insights as valuable as we do.